Let's try again, shall we? Good morning, everybody, and welcome this morning. I have to congratulate all of you who are here, I think, for two reasons. One, for getting to the last day of the World Health Summit. It's been pretty full on, it feels like, over the last couple of days. And secondly, for getting up early enough to be in the room. So I'm very grateful to you all for being here and joining us as we spend the next 90 minutes talking about how AI is moving from hype into reality, where we're actually starting to see tangible and useful applications in health. I'm Dr. Susan Thomas, and I lead Google's work in health here in Europe. And I also look after the clinical teams that support both our research endeavours as well as our work with enterprises. So where the research is done and where it gets put into action. And I'm joined here today by this amazing group of people who will help me unpick how we're turning AI into reality and tell us about their experiences of that. And I'll introduce them shortly. And I promise not to speak for too long so that we get the full wisdom of the group, but I am just going to spend a couple of minutes setting the scene. How many of you over the last 24 hours have used your phone to navigate your way here, say using an app or maps, or have Googled something to find out and read that little summary that comes up at the top now? Quick show of hands. Right. So everybody here, pretty much, has used AI in the last 24 hours in your daily life and not really thought about it, right? You've just used it. And it's now like that. It's just infused its way into our daily life. And yet when we come to healthcare, it's not quite so straightforward. I think all of us who are here delivering that, trying to deliver digital technology and change, in particular AI, find that in the day-to-day. The challenges that health systems the world over are facing, regardless of context, are more similar than they are different. Increasing demand for services and care, constrained supply due to funding issues and the availability of workforce. These things are pretty much universal. In England, at the moment, we have a shortfall of nurses anywhere between 30 and 50,000, depending on who's doing the counting. And in a report published last month, the WHO estimated there will be a shortfall of 11 million healthcare workers by 2030, with the greatest impact being felt in low and middle income settings. Digital technologies have been touted as the cure-all to these challenges, and AI, I guess, is the latest of these. I asked Notebook LM, yes, a shameless tout for a brilliant Google product. If you haven't used it, go and check it out. I asked Notebook LM how many times AI was mentioned in the NHS 10-year plan, which was published earlier this year. For those of you that are interested, it's 82. It was a 170-page document, 82 times AI was mentioned. And that compares with 2019, when the last 10-year plan was published, and it was only mentioned 5 times. So you can see in that short time how things have changed. Or in India, where the term healthcare appears 72 times in their national strategy for AI, indicating what a key sector it is in India for AI transformation. This time last year, Karen DeSalvo, our former chief health officer at Google, sat with a panel of equivalent luminaries and talked about the promise of AI to transform healthcare globally. And I remember really clearly the excitement in the room as the panel spoke. But we know there's often a pretty big gap between the aspiration of technology-driven change and the reality of actually implementing things on the ground. So we're going to spend the next 85 minutes or so hearing from this panel, who are some of the folk, I think, who are really succeeding in bridging that gap between hype and reality. So let me start by introducing them to you. First, we've got Sievert Weiss, co-founder and medical director of Ambos, which is an AI-driven clinical support and medical education platform providing up-to-date best practice healthcare for over 2 million clinicians globally. Then we have Richard Nagar, who has flown in from New York to be with us today. Thank you, Richard, who is a physician working at the frontier of global health. He is CEO and co-founder of Cushy Baby, an AI-powered community health worker platform reaching over 50 million beneficiaries. And he's also a full-time pediatric intensive care doctor who will be back on duty tomorrow morning. So thank you, Richard, for being with us. Then we have Jakob Nielsen, who is the executive director of Healthcare Denmark, a public-private partnership and not-for-profit organization representing the Danish healthcare and life sciences ecosystem internationally. And finally, last but not least, we have Joelle Burrell, senior director of research and engineering at Google DeepMind, where she leads Google's research efforts in healthcare. So running order, so I don't get into trouble with Marco at the back. We're going to have a conversation up here on the stage till just after 10 a.m. Then we'll open up for 20 minutes or so of questioning. We'll have some roving mics to take questions from the floor before coming back and wrapping up by 10:30. So I'm going to start with Sivert and Richard, if I can, who are both co-founders of AI platforms that are starting to see real traction. Sivert, tell us a little bit about Amboss and how you've built AI into that service that you're delivering.
Yeah, so maybe first of all, Amboss has been around for 13 years now, so it's maybe before the big wave of LLMs actually. Today, we would say it's a lifelong medical knowledge co-pilot for medical professionals. And before the term co-pilot was popular, basically we described it differently, but now this is very fitting. And you would wonder, why do we even need this? Yeah, like healthcare professionals, they go to med school or nursing school or the likes. The problem is that medical knowledge basically doubles every 73 days now at the moment. So there is a big difficulty to keep up with that for any human being, despite physicians usually being rather smart. Yeah, it's very, very difficult, and we help with that. And basically, we're providing a tool at the fingertips of these professionals to make informed and evidence-based medical decisions. Yeah, and we not only help at the point of care directly when they need the information on certain dosages or so, but we're actually a companion for their entire life cycle. So that starts at day one of medical school and goes up until retirement, because the entire profession is built on medical knowledge ultimately. Yeah? And it all has to come together. It's a continuum, basically. So we do this for 13 years. We have 2 million healthcare professionals that use us. We have a team of 500 people that is working on this on a daily basis. 1/3 of them are physicians, keeping information up to date, et cetera, and so forth. We've been using AI before LLMs already, yeah? And for us, AI is a tool. Yeah? And it's a tool that you can use as any other tool, like math, maybe also. Yeah, if we use math to solve problems, we use AI to solve problems. It's not a solution in itself. Yeah, it has to be applied onto problems and generate value. Then, yeah, and for us, the value that we get out of this is faster access to evidence-based medical information for healthcare professionals. Yeah, and that's one of our main KPIs. Is basically time to knowledge. Yeah, before tools like ours, they would go onto Google, no offense, yeah, and have to sift through millions of blue links, etc. If they even did that, it took a while. For us now, the main goal is to deliver this information within a couple of seconds. Yeah? And in our case, that information has to be very trustworthy as well. Yeah? So it has to be reliable. It has to prove where it's coming from. It is validated by physicians and so on. Yeah? So that is very important for healthcare professionals in Germany. We have about every 3rd physician using the platform on a daily basis here. So a lot of acceptance in that. And then AI on the other side, on the education side, can obviously help scale into more geographies, can help localize content, can help steer basically more personalized learning and so on. And the KPIs we use here is more direct, obviously for us, is like learning outcomes, yeah? But ultimately it could be even more, yeah? With digital learning as a whole, and AI maybe as a piece of that, you can educate more healthcare professionals, yeah? And you are not bound to rooms like this. Yeah? Whereas in med school, still today, I'm also a physician, and 15 years ago, it was like this, that the professor was in front and preaching to 300 students at their...
And you just wrote it down, right?
Yeah, and you wrote it down, yeah.
And then wrote the exam.
Yeah. Yeah, and you don't need that anymore, basically. Yeah?
Yep.
You have hospitals all over the place. Yes, you need the practical experience, but you don't need necessarily to hear from one professor in the same room.
Yep. Yeah. So you talked about one of your KPIs being about sort of speed to information. How do you measure impact? I'm interested in this because I was in a session yesterday where we were sort of talking about some of this and kind of how maybe we judge technology and AI in particular different to how we judge doctors, because we know there's a great variability in medical practice and the quality of care that doctors give, and yet we sort of hold AI to a different level of kind of expectation. How do you measure your impact? Can you see it flowing through to better outcomes for patients? Do you kind of try and measure that as well? Because I imagine some of the information you're serving up would be information that maybe those doctors just wouldn't have thought about or have at their fingertips routinely otherwise.
Yes. Yeah. So I think there are a couple of factors you couldn't look at. So one is adoption. Yeah, the more people we have on the platform and that make use of it in some form, that's a success factor for us. Then, as I said earlier, time to knowledge is very essential for us, because it ultimately keeps in that example the physician engaged. Yeah, the faster they find answers to their questions, the more they will make use of this. Yeah, and we try to reduce that time by a lot. Now, outcomes for patients are a different beast. Yeah, as you laid out. Yeah, so we have done some studies ourselves. Yeah, but they are not like randomized, controlled, double-blind, etc. Yeah, but where actually physicians would change their decision if they consulted Amboss on their question in about 30 to 40% of the time. Yeah. So, and that doesn't always mean it was a life-threatening thing that was avoided, but it was definitely a better decision. Yeah. And so that's our assumption. That is what we can measure as like the input factors. The output of better patient outcomes is a bit more difficult to assess for us. Yeah.
And final question at this point. Where are you thinking about going next with your products, and how are you going to use AI to drive this even more?
Yeah, it might sound actually very boring, but we just continue what we do with all the tools that are available. AI is one of them, to make this experience even better and even more adopted and even more maybe localized. Yeah, you know that there are in medical knowledge, there's a hierarchy of knowledge, and you start with, there's the research, then this is distilled into the guidelines, then this comes into maybe local standards in hospitals, like standard operating procedures, which are still based on the guidelines, but they are flavored with the local coloring of, here we have these bacteria that are resistant to this, and so on, so we always take this antibiotic, and things like that. So we could go with AI as an amplifier, basically, into more localized knowledge. Yeah?
And do you do different languages already?
Different languages, yes. Yeah, all of these things at scale that can be amplified with AI.
Thank you. Going to move on to Richard, and I guess the same question to you. Tell us a little bit about Cushy Baby and how you've started to incorporate AI into what's happening there.
Yeah. Now, on a lighter note, I will say that I am an Amboss user. I'm a Google Maps user. So thank you both for your contributions. Certainly, this is an ecosystem and community, and we can all benefit from it. Cushy Baby, what we do is we build data-driven public health systems. We work with departments of health at the state level in India. And our goal is to really close the feedback loop between data, insights, and action. If you look at the public health landscape now, there's a tremendous amount of data that's being generated by community health workers, new forms of data that's coming in from satellites, if you think about the climate data that's being processed. And you're getting a lot of data and even some insights, but those insights may start to become overwhelming for those who have to act upon them. And really, we want to think about how we can make those insights actionable and easily able to integrate into existing workflows. So we work across different levels of the public health value chain. For community health workers, we're using AI in a few different ways. We're using it to first see if we can triage with which mothers and children are most likely to have undernutrition outcomes. We use random forest and logistic regression classification models to help predict this. And the important piece is, does our prediction of who is likely to be at risk actually add new information? Or did the nurse already know that to begin with? Mm-hmm. So in our studies, we did see about 60% of the pregnant women would have been additionally screened or prioritized if we had followed our algorithm versus gone based off the conventional rules. So adding something that is novel is important, and also adding something that is actionable. And the second use case that I'll talk about is with using smartphones as a novel biomarker for anemia, another condition that's really important in pregnancy. 12 million women in India are anemic. And if you're anemic at the time of your delivery, that can be life-threatening. But the good thing is that it's reversible, and that the government has these pathways for giving iron, for giving either in the pill form or through an injection to reverse the iron deficiency. So we need to detect anemia earlier, and right now what happens is you prick somebody's finger and you put it into a point-of-care machine, and you're dependent on this big supply chain to get those test strips to the last mile. So now the technology is at the point where you can take pictures of the mother's inner eyelid by just pulling it down. Mm-hmm. And based off the color of the eyelid, you can estimate, is this mother's hemoglobin less than 9 or not? And on the basis of that, refer them to the health center to get further checkup. So we just recently completed one of the world's largest studies on this, enrolling 3,000 pregnant women, and built a classification model that works pretty well. It's not going to be a CBC test, but it can help you make decisions. And that links into the second point, is that the AI should be actionable. You shouldn't just be able to screen for something and not be able to follow up on it. We're also using AI in other ways. Large language models are helping us think about co-pilots or chatbots, so that way community health workers can better counsel their patients. We're also thinking about how AI can make the interaction smoother, so using dictation and transcription so that you don't have to look at the screen. And for health officials, which is a different bucket, we also want to make the interaction more natural. So can they use natural language to ask questions from their public health data and their dashboards? What does that new dashboard even look like? Can they test which of their public health interventions are working, doing A/B testing that you see in different domains, but bring that to public health? And when we talk about geospatial data and climate and health, how do you actually layer these different data points together, data layers together, to allocate where I need to put my limited resources across an entire state? So these are all types of questions that we are hoping to answer with the use of data, AI, and partnerships. And finally, the last thing that I'll talk about is outreach, community outreach. Public health call centers are limited. You can only have a certain number of people, and there are many more people that you want to be able to reach out to follow up. But now with AI and large language models and agents, there is a promise that we will be able to automate some of that outreach while keeping it still human and relatable. So these are all things that we're excited about working, and they will require a lot more research and investigation.
Gosh, that's a lot.
Yeah.
Couple of follow-ups if I can. I think the numbers you shared with us is that at the moment you've reached 50 million beneficiaries via around 80,000 community healthcare workers. So it strikes me the scale you're starting to be able to reach is much greater because of these tools, but also that you're building tools. I mean, you talked about actionable and sort of usable. They're things that aren't intimidating or overwhelming for the community health workers who are having to use them. They're sort of routine ways of using a phone or whatever. And is that sort of a big part of your design and thinking about how to incorporate these new technologies?
Yeah, I think we talk about human-centered design, and for us, we really try to live that. We have a team of over 20 field monitors whose job is to work alongside community health workers every day to understand their pain points, to get feedback on our technologies. And you're absolutely right. Like, we want the technology to be something that adds to their work and adds value without becoming a technological burden. So it needs to be intuitive. It needs to be in an interface that they're already comfortable with. And really, it needs to be human at the end of the day, yep. Right? So we think about how a doctor may be staring at a computer screen and typing a medical note and not making eye contact with the patient. That's not the interaction that we want technology to provide. We want it to be seamless and invisible, but at the same time empowering. So we do think that there is a way for that to be done thoughtfully using the context of smartphones. And we really want to also make sure that we're not adding extra technology debt or technology burden along the way.
And one final question then. You're using Amboss, you're full-time practicing still on the wards and so on. It strikes me there's a difference between how we're thinking about AI in the sort of the world of clinical practice versus the world of public health. and you're sort of having to navigate both of those in your sort of working life. Tell us a little bit about the differences in how you're thinking about those.
Yeah. So as a clinician on the front lines, I think the technology is already helpful. You talked about time to information. You can just speak your question, and as a clinician, you can ask a very focused question, you can ask for evidence, and you get the information back very readily. And it's empowering as you're walking from room to room to ensure that you're up to date with what you need to say. And at the same time, there is this also tension. AI algorithms may be predicting, okay, this patient may be likely to have a clinical deterioration. How much is that adding above the nurse's evaluation from half an hour ago or against your own evaluation? And how much are you relying on it to the point where it's becoming a crutch? So there is this balance that we need to strike where we use it for its value but don't get over-reliant and think about how we're doing that in a very thoughtful manner.
Thank you. Jakob, good morning.
Good morning.
Tell us about Healthcare Denmark and the role it plays in getting technologies in general and AI in particular embedded into healthcare. What do you do?
Thank you very much, and thank you for the kind introduction. And I guess just from the few examples we just heard, gives plenty of reason to why I'm here representing Healthcare Denmark. We are as you said in your introduction, non-profit, public-private partnership representing the government, the ministries, the hospital sector, all hospitals, but also industry, also within tech, but also in pharmaceuticals, universities. And our mission is to establish and facilitate international dialogue on healthcare challenges and how to solve them. And I guess today's session is a very good opportunity to do that. And then, of course, also to bring Danish perspectives into the conversation. If you Google it, I guess I can say that here. Denmark and healthcare, will come up 1, 2, and 3. If you Google Denmark and digitalization, will come up 1, 2, and 3. But from the examples I just heard here, I can see we are definitely not at the forefront in AI. And there's a conversation to be had there, and that's what I hope to contribute with today. How come we, maybe in some of the Nordic countries, maybe also in Europe as a whole, is not as far on the implementation of AI as maybe some other countries in the global south or other places in the world. We can also look to the US, and how can we make that transformation, because there is a clear realization that we need to do a transformation of our healthcare systems. In our countries, in Denmark, we are looking very much at bringing healthcare closer to home. What would be an obvious choice for that? And how do we do that? And of course, I would like to dive a little bit more into what we see as some of the opportunities, but also as we see as some of the constraints in making that transition.
Yeah. You talked there about the partnership that you represent, and it's the private sector, it's government, public sector, and academia, importantly. What is this sort of public-private partnership feels like a really important mechanism for doing things, sort of getting from solutions in the research stage all the way through sort of testing into integration and full deployment. What is the role of that public-private partnership in driving that?
Yes. Thank you. Well, my good colleague and I, we just had a come from breakfast meeting with some German parliamentarians, and at that we brought a report we just published on public-private partnerships, and there was a German representative from a German company there, and he said, wow, that was a brave thing bringing that here. In Denmark, we think it's a natural thing that the private sector and our public healthcare system work together, that the challenges that we face cannot be solved by one party alone. The industry cannot develop the solutions without a very close, intimate, trusting partnership with the public sector. And on the other hand, for the public, our healthcare systems, with the challenges we face, I participated in a dialogue where the CEO of Charité, Heino Kreumer, he said it openly here in Germany, the Charité will look at a 30% declining workforce in 10 years. And it was a different debate, but also AI came up in that context, because also in Germany, in Europe, we're looking at bringing healthcare closer to home. 80% of what is going on in the hospital doesn't have to go on in the hospital. So we have to look at those instruments in making that a reality. Yeah.
Thank you, Jakob. Joelle, you lead Google DeepMind's research in health, and so I think I hope it really excites you to hear how the endeavours of teams like yours over the past numbers of years are now sort of, that work's coming into reality in the work that we're hearing from colleagues on the stage. Given this is about implementation, it would be really good to understand sort of the thinking and the ethos behind the research you do at Google DeepMind. Do you intentionally ground your research in the frame of how will this change healthcare in 2, 5, 10 years? Or is it a bit more abstract than that? Like, where's your North Star as a healthcare researcher?
Yeah, thank you, Sue, and thanks for this wonderful panel this morning. So it's an interesting question in terms of, are we trying to invent the future, saying, what will the world look like in 2, 5, 10 years? I like 10 years for two reasons. The first is that it's roughly the time it takes to train a physician. So the people that are entering medical school today will be practicing physicians, helping all of us 10 years from now. And in many ways, I think we need to anticipate that so that we train them properly. And if AI and generative AI will be ubiquitous 10 years from now, shouldn't we change the way we are training that next generation? Shouldn't we also change the way we are evaluating that next generation of physician? And I'll get back to that. The other reason I really like 10 years is we very often overestimate what we can do in 1 year, but we underestimate what we can do in 10. And I was also here last year, and we were already discussing, many of those topics. And if someone cynical was looking at today, maybe they could say, well, it's a lot of the same discussions, right? How do we really bring technology to the last mile? Because it's hard, because our healthcare systems are very complex, many stakeholders, many different prerogatives in various parts of the world. And they could, say, well, Gen AI hasn't really changed much. As it. But I dare to say that 10 years from now, we'll look back and really see a very significant delta from where we are today. So for us in research, it means that we are trying to look at 10 years ahead, because that frees us sometimes of some of the day-to-day constraints that we have to work with, and that really drives the ambition and make sure that we are looking at some of the biggest challenges we have to face as a society, and try to envision how our research tools can come and help with those. So one thing maybe to frame this discussion a little bit, I lead teams that are dedicated to healthcare, but I also have teams that are working on foundational models or AI more broadly. And 10 years for us is actually a very, very long time, because a lot of the changes we're seeing with generative AI are at the point where the models have increased capabilities, where we believe they will be able to do a lot of tasks that today they are, sometimes good at, but they also fail a fair amount of time. You asked, Gemini to count. I'm not sure if you've checked manually. I hope it gives you the right answer, but there are things like that are, pretty easy for us, multiplications and whatnot. And the models, if they're using tools, then a calculator, then they will do the right thing. But out of the box, sometimes they don't, right? And there are many of those examples, which is why I have a job, right? Which is why there's a lot of research left to do in AI. However, we really see that gap is closing. The same is true with multimodality, helping understand images, helping understand videos, right? A personal example I really love is I have a new bookshelf, so I was putting all of my books there. And I remember back in the days, being with my notebook, writing down every single book I had, because I wanted to either lend them to people or know what my collection of books was. And that was a very manual and time-intensive process. Now you can just, take a picture, take a video, and it will automatically do that list for you, right? So pretty nice as far as a capability. A couple of years ago, it would have completely been perceived as impossible. However, it will today still, I think, invent a few books that I really don't have. And so, we are working hard to to close that gap. So there's still a lot of work to do. But if we put ourselves 10 years from now, and we can really envision models where those capabilities are actually working reliably for all of those tasks. What does it mean for healthcare? What does it mean for the world we live in? And one very important aspect of the work we do is really to try to figure out with the physicians, with all the stakeholders and the nurses and agents, so not just one model, but potentially a lot of models, each specialized for particular things, what will that environment look like? And what are the types of products or the types of interactions we want to have to really make the most of the technology? And there's still lots of unanswered questions to those types of that type of research.
And one final quick question for you before we get into a conversation. I wonder if you could just tell us about maybe the most exciting thing that we've launched or done recently. Yesterday we were in that session where Isaac from Indonesia, I can't remember his role, was talking about how they were using MedGemma to screen, I think, 50 million people for tuberculosis, which felt astonishingly exciting. So maybe you could tell us about what your most exciting thing that you're seeing out there is.
Well, you gave the question and the answer, so in some way you stole my thunder. No, I've been very, very excited about MedGemma. So Gemma is our open weight model. It's a model that anyone can download and use independent of where your data sit, right? And because of that, it really means that anyone, students, physicians, researchers, developers, can leverage that technology to build on top of it. And I think it's very important for me that we are bringing the technology close to the point of care, because there's so many ways the technology can be used, even if we actually, and we do spend a lot of time with partners, with physicians, et cetera, but there are not enough of us, right, to really envision all of those potential use cases. And then we would make up a world that doesn't exist, right, even if we tried our best to really answer all the clinical needs that might exist everywhere in the world. So I think it's a much faster way to bring the technology where it's needed, to put it out there and then give the tools also to further build on top of it, right? It's not a final product. MedGemma is an open model that has been fine-tuned on medical data. So it has seen enough radiology images, for example, to be able to be used as a foundation on top of which people can further build and validate the technology before deploying it. But I'm really excited about that. And this is also a model for which we are continuing to improve its underlying capabilities. So that's I think one of the ways we'll see like the last mile being the fastest, because we are giving the technology to as many people as possible.
Thanks. So that's been half an hour or so of pretty overwhelming positivity about what we've heard, what AI has done, what it can do, what it has the potential to do. So I guess my question to you all is, if that's the case, why are we having to have a discussion about implementation, right? If it's so good, what are the main systemic barriers that are still making implementation hard? Because although you talked about what you're doing and how MedGemma is working and so on, it's not easy, it's not straightforward, right? So is it regulation, trust, procurement, usability? So maybe I'll just quickly go down and just your one-word answer of what you think the biggest barrier is, and then we'll get into a discussion about that. Sivert.
Yeah, I think maybe I turn it the other way around. For us, what has been most helpful is to think from the end user perspective and design it for that person.
Right.
That has driven adoption tremendously.
Super. Richard?
I would say trust.
Trust.
Trust is the most, a bedrock. We need to be able to trust the models, the predictions, the tool itself, and you need consistency and reliability for that.
Okay. Jakob?
I hate to come after, so I would also say I also wanted to say trust. Because,
that's great because it's the next set of questions.
Yeah.
So,
if you want me to expand on that, that's more than one word. But
yep, that's fine.
No, because that is the fundamental core of making such changes between, you can say, the most fundamental pillar in any society, the healthcare, whether it's public or private, and then the contract with the citizens. So trust, for sure.
Okay. Joelle?
trust. Maybe I could say it a third time, but if not trust, I think, and you also brought it up, collaboration is absolutely key, public-private collaboration, but also the entirety of the ecosystem and all the stakeholders, right? It's something that's very important in health. It's also absolutely critical in innovation more broadly. People often look at the Bay Area and wonder how much, why so much innovation comes out of there. And I really believe an ecosystem in which all the players are trusting each other and respecting each other and understand why they need each other is key to making this work.
Super. So let's delve into trust. Thank you all for teeing me up. I'm going to start at the other end this time. And let's just kind of think about this a little bit. We often say at Google, and I think other people have said it as well, that health moves at the speed of trust, right? It is really important. And yet the tech industry sort of famed, I think it was Zuckerberg who said, move fast and break things. And those two things seem a little bit contradictory, right? We need to build trust, and yet we need to move fast. And we know we do need to move fast in healthcare as well because of all the challenges that we've set out. So from sort of your high-level, sort of almost structural perspective in research, and then we'll come to the policy and sort of partnership side, Jakob, how do we reconcile these two sort of almost seemingly contradictory positions?
I think that's a very, very good question because it also explains why health tech doesn't move at the same speed as tech more broadly. And I think Mark, but others didn't say that for the sake of breaking things. It's the idea in moving fast and potentially breaking a few things is that you're putting your tools out there so that you can get feedback and improve the tools, right? It's really the idea that, our teams are fantastic, but, they have some ideas in their heads in how things work. And if they get that to be too perfect before they put things out, then they realize that they've spent a huge amount of time and money on something that wasn't the right problem to solve, right? So it's not about breaking things for the sake of breaking things, but it's daring putting things out there maybe before they're perfect, right? So that you get feedback and you improve. So how do you do that in healthcare, right? In a previous life, I built surgical robots. You don't put your surgical robots out there to then be able to improve them, right? You first have to really make sure that they've been cleared by the right regulatory agencies and for very good reasons. But you have to find ways to get feedback on your technology, right? You have to find to have sandboxes or trusted tester programs in which people know that the tools are not ready, but they've been validated for either a smaller number of use cases, or they are being deployed in a safe environment with supervision. So, for example, we've built AMI, which is our research program, Articulated Medical Intelligence Explorer, to see how far we can go with diagnostic intelligence with large language models, and the way we are, the phase we're in now is to work with BIDMIC, the Beth Israel Deaconess Medical Center at Harvard, to be able to see, in real life, how is that helping? How are people actually using the tool? But of course, there is a proper protocol and the right, RB approvals, et cetera, to make sure that it's not going to be used left and right in a way that it shouldn't be. So I think finding ways to lean in and have more of those trusted tester programs and ways where people are embracing the technology in a safe manner, but before, in many ways, it has been completely, fully tested and approved, is absolutely key to make sure we actually build something that works for the people that are going to use it.
Thank you. And Jakob, I think you said trust is the currency of adoption or something like that earlier. What's the single sort of non-negotiable step that the private sector has to take in order to build that lasting trust with the public health systems, do you think?
Thank you. Now, I'll say this just, maybe there's a danger I'll get kicked off the stage in a second here, but actually if you look also in terms of trust in Denmark, it's actually one of the countries in the world where the citizens have the highest degree of trust in the institutions, including the healthcare system. And why is that? Because it is a contract between those two. There is a partnership, if you so can say. So if we can establish that also when it comes to bringing AI for real We all know that doctors use it today, even though they don't use, not officially, right? We know that the GP use it. We know that it's being used in hospitals, but it's actually not the real solution in many instances. But it is to establish that partnership, because if you have that, then you have a collaboration. And if you can have a collaboration between, we believe, the public side and the private side, you actually have a competitive advantage where we can add something to a conversation where maybe also other places in the world will look into that, because that is unique for Europe, and that is, of course, the interest that we in Denmark have at stake.
Thank you. So I think it's interesting. It's almost like trust and collaboration are two sides of the same coin, right? The trust allows you to collaborate, collaboration builds trust, and so on.
Yes, and there's also a lot of prerogative on the government side that you need to provide. You need to provide, a clear pathway.
Yep.
You need to have long-term policy commitments. I can also maybe dive into some examples on that, later on. But of course, government need to deliver for the private sector. So it's not. It's a two-way street.
So, Sivert and Richard, shifting from policy to the bedside and to the community, what's, from your perspective, and let's start with you, Sivert, and then we'll come to you, Richard, what's the most sort of critical action that you take to build trust with your users, your 2 million medical, your clinicians and students?
I mean, we are in this information knowledge kind of business, and that knowledge is just not plain text, right? It has to be, as you said, to generate trust, it has to fulfill certain criteria in the eye of the user to make it trustworthy. Yeah? In the moment you consume the information, and then maybe over a longer time, and from a healthcare professional perspective, it needs to be reliable. Yeah, it needs to be up to date to the today's standards. It needs to be evidence-based, and I need to be able to ultimately refer to where is this coming from. So we are not inventing any of that. We are not inventing medical knowledge, but we are distilling down the core that needs to be applied at the point of care. And if they have a couple of these questions and see what they get back to their questions, I think that builds a lot of trust in our case.
Thank you. And Richard, in the public health sphere, it feels like it's even more multi-layered in a way, right? Are you having to build trust with the health officials that you talked about, with the 100,000 community health workers that you're currently working with, or the 50 million beneficiaries, end users? And actually, I imagine it's all of those in different ways. Talk to us about that.
Yeah, I mean, so I think you're absolutely right. It's very complex. We think about trust for different types of users, different stakeholders. It starts with just even something as simple as, what does informed consent look like? We're collecting health data. You have a health provider and you have a beneficiary. Do they understand the terms of service when they hit accept, or you've hit that they said accept? And then how is their data being used? And then on top of that data, what types of algorithms and other techniques are we applying? To what extent can we trust those algorithms? Like, is this a software as a medical device? Do we have to go through these long RCTs in order to evaluate whether or not these are going to be helpful? And at the same time, are those evaluation mechanisms going to keep up with the pace of technology? Because you're evaluating something and 2 years later, technology is at a completely different place. So I think really the important piece about trust is transparency, being very clear about the data that we've collected and trying to open that up to collaborators, being very clear about the failures, what doesn't work, and where we have had gaps and limitations, either from a model or, not achieving its targets, or from an implementation standpoint. There are different levels of barriers that can come in the way, and just being clear about what worked and what didn't. And at the center of it, keeping the human and the end beneficiary, the end user, paramount. Because if you can gain their trust and kind of co-design with them, then the whole system is more likely to succeed.
Okay, thank you. I'm going to move us on to how we measure things, whether that's success or impact or performance. And I'm going to start up this end, and people do jump in as you want. Joelle, I know you're thinking a lot about benchmarks at the moment and how we evaluate and measure performance of our products when they're in research and as they're moving through into sort of being productized. Tell us about that. It feels like a really important thing. It's almost a science in itself, isn't it? Now?
Absolutely. So I don't know how much people here have followed the large language models, the Gemini of the world. The way this works, because the research came from academia, and in academia, people like to have those leaderboards where you can really stack rank all the models and see against known benchmarks, so particular data sets or questions that have been shared, how well your models are doing, right? And historically, that's how, if you look at the literature, that's how all of those different LLMs or techniques were compared, right? If you manage to improve a little bit, you become state of the art, and then you have this table with a lot of numbers that shows that, yep, one of them is higher, you can publish, and you have a new paper out. And then in the push to really get those large language models to the capabilities that they have today, this is still how it works, right? You have arenas or leaderboards where people really compare which model has the best capability in coding, in understanding images, etc. And that's, from a technical perspective, the way then we improve things, right? We try to train the model on particular aspects of or set of capabilities, and we look whether those numbers are getting better. And so, like for everything, the test matters, right? Like how you're going, same way that, I think in med school, you're going to train a particular way because you know how the test is going to be, right? And learning to the test is a failure mode. And the same is true for our large language models, which is why benchmarks are so important. If we want the models to be good in a particular language for healthcare, for a particular type of use cases, then we need a way to measure that. And I think what you're alluding to is we've been really trying to make sure that not only do we do our own benchmarks, but we're also sharing our methodologies for building benchmarks so that a particular country in a particular language for a set of use cases would be able to say, okay, I'll look at all the models, all the solutions that industries are offering, and I'll have my own benchmark to say which one of those is the one that works for me. And I think that's absolutely key also because it keeps us on our toes, right? If we see a benchmark where we're really not doing a good job, our people are incredibly competitive. Like, they will not be happy to not be at the top of the leaderboard for that particular thing. And it can be tropical disease in a peculiar country. It can be many things, right? A lot of our engineers and research scientists are pretty agnostic, but they do want to have a model that performs well. And so that's yet another reason, I think, where benchmarks and showing the gaps and really articulating where it doesn't work is incredibly helpful.
Thank you. Jakob, from a sort of public-private partnership, what's your key metric? How do you measure success?
Yeah. Well, it's elementary, dear Watson, isn't that how Sherlock Holmes framed it, right? So first of all, you have to agree on what you measure. And here it's just very, very important. Don't estimate the power of the healthcare system and the healthcare workers. So start at the bottom. Any successful, whether it's AI or any other technology, any successful implementation in a healthcare system is rooted in local context. You gave some great examples. I believe we've heard some, but you need to get the buy-in and the agreement. What is the measurement in Denmark? So we also just teasing with this, but the government took initiative in our latest life science strategy, where across the board they made a national innovation index for the hospitals, because also in Denmark, we have this not invented in my backyard. It doesn't even have to be invented in Germany or India. It's from another part of the country, and the hospitals don't want to use it. So to have an agreement on what is an index for an innovation and how do we want to implement it. So that is a place where a government has a role, and where then the private industry then have an even playing ground in terms of bringing in new innovations into the healthcare system. I don't know if that answered the question.
It's great, thank you.
So if I may, very quickly,
yeah, of course.
because I mentioned mostly benchmarks. By no means do we think it's the only thing, right? It's definitely not enough to know whether innovation is going to work in the real world and bring real impact. But it's where we're starting from a research perspective. So that's why it's so important for us. But of course, at the end, you have to measure whether things worked when deployed out there.
But if we're putting out models that aren't good, then
no, that's the bare minimum. Yeah, that's where we have to start.
And I was thinking when you were talking about that it's really interesting how the work of the health team that I sit in now at Google, a lot of our time and thinking is spent on how do we evaluate, like how do we know that a model is good at tropical diseases in whatever, in certain languages, and what are the rubrics and the evaluation methodologies? How do we think about context for that? And I know there's members of our team, I see Heather here, who spends a lot of her time thinking about that context and making sure that we're building models that are right, not just for Silicon Valley or for King's Cross in London, but are right for people wherever we are. So I'm going to come from that level to sort of, I guess, ground zero almost with Richard and Sivert, and how you think about success, which is interesting, I guess, because there's sort of commercial success, there's usability, there's time, and there's all sorts of different metrics. But how are you thinking about that, to start with, Richard?
Yeah, so we think about impact in a few different ways. For health workers, it's can we use that data, that tool or technology to transform how they're doing their healthcare practice in a way that they feel more empowered and in a way that will ultimately lead to either efficiency or efficacy gains. So we gave the example of using the smartphone to screen for anemia as opposed to pricking someone's finger, the timeliness of being able to get that information and refer the patient. At the health official level, it's drawing a line from that insight into that policy change. So, for example, at the state level in Rajasthan, India, we are using data and analytics to help target which groups across the whole state need to be prioritized for TB surveillance, and changing how they're framing their whole strategic policy of rolling out this health program. So, really, for us, impact is around developing these rich case studies that show technology in a broader context of stakeholders, the right problem statement, and then how it may not track all the way to an end health outcome, but to a process outcome at least.
And just while we're on that, I'll come to you in a minute, Sivert. Just thinking about equity as a measure. We're sort of thinking about how our tools are used and so on. We appropriately get anxious about digital exclusion and how maybe the lack of access people might have to technologies have a greater impact on communities that have been marginalized, whether that's, in the global public health field or indeed, in the UK, say, where we know, women in Barnsley, which is a town in the north of England, have the lowest healthy life expectancy than anywhere else in the country. They have a healthy life expectancy of 52 years compared with, I think the average for women is like 70 years or something. And they have really limited access to these tools and technologies. So we know that digital exclusion can impact negatively on, or rather there's a risk that digital exclusion can impact on people. But actually, if we get this right, AI could have the potential to close this divide, I think. And like sort of your work with community health workers, where you're able to scale and empower those workers to do things differently and not have to carry around big, cumbersome paper things and be able to work offline and more efficiently and do the anemia stuff. Actually, the reach and the scale has real potential, but it's a tightrope, I guess, isn't it, between digital exclusion and digital access?
I see a huge scope for potential. I'm a big optimist here, and I'll give an example from Google itself. Google's Directions API, which powers their map, the Google Maps interface. We're using that to find out the driving time that it takes from every one of the 40,000 villages across the state to the nearest public health hospital.
Amazing.
Then to help, and this has been done in other country settings as well, to help figure out how to best allocate sparse resources. Where do I need to build my new emergency hospital or trauma center or cardiac center? And similarly, we're using the data from these newly digitally empowered community health workers to have a village level poverty index, multidimensional poverty index, for the first time at the village level, where you can actually see if I go a few kilometers in one direction, the picture could completely change, and to help develop micro strategies on the ground. So I think technology has immense potential to actually uncover the truth and bring transparency to public health. So I'm very much in the optimistic camp. At the same time, we do need to make sure that the technology is accessible to everyone, and we need to focus on that as well.
Thank you. It feels like being very deliberate about it is important. Siva, we talked a little bit about sort of some measures of success. Just take us through that from an AMBOSS perspective.
I think I would like to second Jakob's statement here. I think it's all about adoption at the very point that you're looking at. Yeah. So how do we make it easy enough for healthcare professionals to use these tools? Do they really help them? Are they gaining time by using them? Are they getting more efficient and things like that? So adoption here is the ultimate success factor. There are then probably a couple of proxy metrics underneath that lead to that. So convenience, and what is actually convenience? In healthcare information, it's like, again, probably high quality information. It's how fast you get there and so on, and how you can consume it. So. But I totally agree, and this is why I said earlier, I think it's about having the user in mind when designing those systems, and have them sit at the table or have them even design those systems. I think that's tremendously important, because otherwise it won't work. And we see adoption, as you said earlier. So yes, totally, I see a lot of potential in AI and what it can do on a larger scale to drive these things. Again, it's not a solution in itself. It has to be applied to relevant problems, and then you have to get value out of that. I do think that we really need to double down on thinking it from the people that use these systems, and then it will take off. And there are all these generic AI systems already being used. There were in the past certain messengers used, so digital instruments that you shouldn't be using in the hospital, but it's just so convenient that you can use them, and you send sensitive data to your colleague who is on the same system. So that's happening. It's happening similarly with now chatbots and the likes. So how do we make sure our safe systems and reliable systems are as equally convenient as those systems?
That's a really good point. So I think I've heard from all of you, it's sort of adoption, but sort of targeting the end user from the ground up. If we get that bit right, that's what drives adoption. That means you're doing things that will drive your success. Before we open to the floor, I just want to do one last delve with you all, if I can, around workforce implications. I talked earlier about workforce shortages, which we see globally, and lots of people saying, AI is going to transform the face of medicine and how we do medicine. I think it was Geoffrey Hinton, the godfather of AI, who said in 2016, in 5 years, we won't need any more radiologists. Waves to any radiologists in the room. So maybe a little bit premature. How do you see AI changing the face of the healthcare profession broadly, not just doctors? We've talked a little bit about training, and you're obviously thinking about how we train differently. We need to train people with different skills. If you're getting Amy to do, or you're getting diagnostics done in a different way, or you have a clinical assistant as an individual that helps you navigate your way, is your interaction with a GP different? Do we want GPs to have a different set of skills to what they have currently? Open to the floor, really. Any thoughts on that? We'll go Siva and then Joelle.
Yes. Please go first. No.
Oh, yeah, thank you. Actually, I'll bring 2 points also to build on top of what you were saying, because we talked a lot about conversational agents, but what's happening with generative AI, I think it goes way beyond those conversational agents. You've probably all heard of AlphaFold, which is now allowing us to predict the 3D structure of all proteins known to humanity that got the Nobel Prize last year that was awarded to Google DeepMind, Demis, and my colleague John. And for that, so it has changed how we do molecular biology. And the reason I bring it up is that there are a lot of those types of examples where we are now able of making predictions for which before we had to build very complex systems or do experimental validation with, again, very costly and complex hardware mechanisms. One thing I can bring up is weather prediction, right? For many years, those were done by very complex physics simulators, and we've now built models that can do a better job than those simulators and are much faster at doing those predictions. And I think that I wanted to bring that up in the context of what you said about being able to leverage a map API to then be able to say, in which village or where do we need to put those new healthcare facilities. The amount of data now that we have about the planet holistically, where we can look at water, we can look at traffic, we can look at air quality, we can predict the weather. There's so much that I think there will also be, to bring back that to your question, a lot of new jobs that are needed, right? We'll need people that are capable of looking at all of that data to then distill it and inform public policy or inform, a decision that a particular city is making in terms of how to distribute resources, et cetera. And I think we're not yet at the point where it's just, snapping your fingers and you can immediately tell, how you should distribute that amount of precious resources. But we're not very far, and we can definitely do already make already better informed decisions when we take a really analytical approach and we leverage that data that was just not available a couple of years ago. And it's data at the time of making the decision, but it's also then longitudinally being able to evaluate and re-steer as needed. So I think that's the first point I wanted to bring up, that really there is a lot of new things that we'll have to do, I think, if we and tomorrow the way we deploy those solutions globally is going to change because the tools that we will have at our disposal are really changing profoundly. And then I wanted to get back to what I said at the very beginning about students. I spend a lot of time evaluating models. I think the healthcare profession is spending a lot of time evaluating students and then professionals. No one today is evaluating the intersection of both. No one has looked at, if I have a physician with a model, what are they capable of doing and not doing? And the other thing that is not really happening, I think everyone here has probably asked already to a LLM some of their own health questions, but how many of you have pulled your phone in a physician's office? A handful. You're brave. Very few people dare. People tell me I wouldn't dare do that in front of my physician. But actually, this is a real question, meaning what is the best interaction between a patient, a physician, and this knowledge that you have also mentioned, has been distilled into a way where you can access it immediately. And so the reason I bring that up is that I think it also means we'll need to change how we train. We'll need to change how we clear people for a given set of responsibilities. And we need to further experiment to really know how to make the most of all of this.
And I think the interesting thing there, sorry, Siva, is you talked earlier as well about how you like the 10-year horizon, because that's sort of length of time that we need to think about in terms of 5 or 6 years at medical school and then your sort of junior years as a doctor, equivalent with nursing as well. And we know that getting changes into medical school training isn't easy, right? It takes a long time. And certainly in the UK, each medical school sort of does its own curriculum, makes its own choices around that. So by the time we get those changes built in and students coming through the other end, actually we're potentially beyond that 10 years, right? So it's something that feels that we can't wait, right? It needs to be being thought about.
Yeah,
now.
And it's also very hard, right? Because you talked about over-reliance on the technology, and people ask that question also with K-12, right? Oh, should we teach AI instead of, reading and writing and whatnot? And absolutely not, right? Like you still need to teach kids to read and write, and it's much more useful to them to understand math than to start playing with AI tools, even if they need to understand the limitations of those tools or fake images, et cetera, right? So there is a right amount, and I think the same is true for med school, right? I'm absolutely not saying we need to completely change the basics and not have them understand anatomy anymore or whatnot, but I think figuring that out is really hard because of that. Like we also have to figure out how to make sure we equip everyone with core knowledge to really have what's needed to use the technology properly and not over rely on AI. But saying that we shouldn't change anything is not the right answer either.
Siva.
Yeah, totally. I like what you're saying. I can only echo that to the fullest. I think maybe about two potentials here from a healthcare professional perspective. One is, I think, digital tools and AI specifically can free up healthcare workers' time. Yeah, of course, can make them more efficient, and those precious resources that we have, and it takes a long time to get there, they can be better used. Yeah. And there are multiple areas where this can happen. One is, in our case, is knowledge, but just the admin burden of healthcare professionals is so high. There are multiple solutions in that regard as well. Now, imagining all of that coming together, great. Yeah. And by the way, at least in Germany, we're very far from that. We always talk about like, oh yeah, AI models predicting like the right diagnosis and so on, like basically the holy grail of what you can do in medicine, and basically replacing the physician and all of that. While at the same time, in German hospitals, we send faxes around to understand what the patient had before they came to the hospital. Yeah, so that's the reality. And so I find there's quite a gap between these two parts. But yeah, ultimately the potential in freeing up time is definitely there. The other question is also, could we train more students, again, to the point earlier, when education is not bound to physical spaces, but we can do it anywhere, anytime with digital tools. We can scale it endlessly. Great, yeah. So we could train more of these resources, be it physicians, be it some kind of healthcare worker, community health worker, nurse, whatsoever, and they can still train in hospitals for the practical part. And then I totally agree to your point, which is, what do we train them on in this time, where we have these tools that are accessible, that help us with all of what used to be the sole power of the healthcare professional. Now think about the image of a physician maybe 20 years ago, maybe in some heads it still is, the demigod in white, who makes all the decisions because he has studied medicine and practiced medicine for quite some time, and it's, as we said earlier, it's basically impossible to live up to that standard because no human can digest all of that information. So you need help, and that help has to be as automatic and as standard as like using the stethoscope to hear how the heart sounds or the lung sounds. It has to be a tool. So we have to get away also from the picture of the physician being this demigod in white to a person acting maybe on eye level with the patient who is already very informed, because he asked all those questions to an LLM coming before the consultation. And now, where do they meet? And how do they make a decision? And also, I want to add, medicine is an imperfect science. It's not deterministic. So it's not just you put something into the machine and it's 1 or 0 or black and white. It's a joint process to get to a treatment plan between the physician and the patient in a form of a shared decision-making, where ultimately both really understand what they're up to. If you confront a patient with, like, you have some sort of cancer, now we can do, which is maybe guideline recommended, we could do a treatment with this drug, but it's chemotherapy, so it will do quite some harm on the way for a potential prolongation of your life expectancy of 6 months. Now, what's the right decision? The patient has to decide. Do I want that? Is this how I'm going to envision this or not? So I think there are a lot of interesting parts we can touch upon with AI, and we can leverage with AI, and we need to figure out still.
And one of the things I think that's interesting, I haven't been able to quite work out yet, is if we're getting AI to do, say, some of the routine stuff, and that you've just talked about, and doctors aren't being asked to do that any longer, and we're asking them to do some of the more complex stuff, how do you do those edge cases? Because, like, I remember when I was a student, the reason that I ended up being able to know what I don't know, a pneumonia sounded like or a mitral valve regurg sounded like was because I listened to hundreds of normal chests, right? And you know what a normal chest sounds like, you know what a normal heart sounds like, and then you can distinguish it. If we take, like, how do you balance that? If we get radiologists, Geoffrey Hinton again, you know, if we take some of those routine scans away, but we still need them on the edge cases, how do you have the knowledge that you need to build to be able to get you to do the art bit that you said that it's not black and white? Anyway, any final points? There's something philosophical. We should probably move to questions, otherwise I'll get in trouble. There are many questions. What I'm going to do is take 2 or 3 questions, and I'll go this side first, and I'll take them, and then we'll ask the room. So I see this woman straight ahead of me here with the grey top on, and then there's somebody in red here, and then somebody, the chap just in front of the lady with red. Yes, you, it was. It wasn't you, it was the woman next to you, but that's all right. Okay, okay, all right.
Thank you very much, and thank you for such a stimulating panel session. I'm Louise McGrath. I'm the Deputy CEO of a UK non-governmental organisation called Global Health Partnerships, formerly THET, and we work to support health system strengthening and health workforce development in low and middle income countries in particular, but looking at mutual benefit. And I think you raised some really stimulating points about digital exclusion. And one thing I was thinking in relation to the use of AI medical models for building global health equity, how do you ensure that the tools have incorporated data from those contexts to make the tools more relevant to those low and middle income settings? Thank you.
Thank you. And then this woman here in the red jacket. And then if you just pass it to the gent in front of you.
Okay. Thank you so much for the conversation. I know CVET talk about user-centered design, Richard talk about co-designing solution with healthcare, and Jacob talk about public and private partnership. But here's my question. Sorry, I didn't introduce myself. My name is Farida Tibedon. I'm a nurse and digital health advocate. And my current MBA dissertation focuses on digital health readiness among healthcare professionals. But what I've found, or what I've seen, is that technology adoption fails when these healthcare professionals are not ready. So my question is, how do we align digital health readiness and human factors with AI implementation to drive impact? I would love to hear your thoughts about this. Thank you.
Hi, I'm Dr. Shivam Natarajan from UK. Susan, you have a lot of UK colleagues here. My question is to Joel and Richard. First of all, Richard, awesome work. How did you manage to enter into India? Yesterday, I was with the ICMR India, and we have 650 million people suffering from chronic diseases in India. So the only way across to is through digital means. My question is, you said humanize, and Joel, you said healthcare doesn't adopt technology as much as other industry. The reason why I'm combining those two is this challenge, or I'm a surgeon, I'm passionate about technology. I also love about tender loving care. But are we as clinicians ourselves putting a barrier in this implementation of trying to humanize digital healthcare too much that we do not scale it up to that extent? So if you look at travel, if you look at retail, if you look at every other industry, they want to reduce human touch points, and that's how they're digitalizing it. Whereas we keep on saying that, look, I'm a good surgeon, I love my patients, but is that humanization at every point in digital care required, and is that being the barrier? How are you going to reach 650 million people with human touch? I'm just asking that, and the reason why I asked that, Joel, is that how do you were talking about measures of how do you say AI is being adopted. What is the measure of AI or technology adoption in an industry? I would love to, for us from this point, go on and say that healthcare does adopt technology much better than other industries. You got this whole room full today at 9 a.m. on the third day of a conference in AI. So please, let's passionately say that
Thank you.
Healthcare adopts technology.
Thank you. Right. There's some questions. I am keeping an eye on time. Don't worry at the back. So the first one was around data in the tools and making sure that we're not just using, I don't know, mammograms from the UK or whatever as we're training these products? How do we get that sort of that context? And it's something we're thinking about deeply at Google. So, Joelle.
Yeah. No, I'll answer that, and I think I'll also answer a little bit of the last question, if you allow me,
That's right.
because they also, I think, come together in some ways. So I would say you're absolutely right. Like, a model doesn't know what it hasn't seen, and we've initially trained our models with a lot of the data that's on the web, and some of it has is health related. A lot of groups in which patients might discuss symptoms and whatnot. And then we very intentionally also, leverage medical data, textbooks or whatnot, to really make sure that for certain conditions, the models are going to do what we want them to do. And then the benchmarks I was talking about, those are very important. So initially, a lot of that was very focused on the data we have. So quite heavily Western data, and for conditions that are more prevalent in those parts of the world. We do have teams that are, for example, you might have seen AfriQA, which came out a couple of weeks ago. Some of our colleagues worked with partners in Africa to help get data that best represents things that weren't represented in the initial data sets, and also have ways to measure that. And then it's what I was talking about with the decentralization and making sure that it's not just the initial MedGemma model or Gemini that knows it all, but that various healthcare systems and communities can collect their own data and build their own benchmarks, and then further fine-tune the model for their own needs, right? And if the training of an initial model is something that requires a lot of compute and special expertise, fine-tuning a model is not that, right? It can be done at the leaves. It can be done in many different countries and settings. And so that's really what I would encourage people to do, right? Like, evaluate the models you're starting from, and if they're not good enough, figure out which data you need and how you're going to measure things to be able to further build something that will answer your needs. The reason why I think there is some relationship between your question and some of the follow-up questions is that it's not just equity of the model, it's also equity in who is using the models. And what we see is different age groups and men and women are not adopting the technology at the same rate. And if this technology, and I truly believe it will, is going to fundamentally change how we practice medicine, for example, but female doctors are not adopting technology as fast as men doctors, we have a problem, right? So it's also really making sure that all of our stakeholders have access to the technology, lean into leveraging the tools, and that we reduce some of the barriers to adoption. And the reason why I think this echoes a little bit of the last question, I wanted to bring up an example of a startup company called Doctolib. So Doctolib in France now is the way you book any medical appointment. And if you had told me 20 years ago that France would actually be at the forefront, one of the countries in which any type of medical doctor, anyone can find them online and then book and show up and they will get care, right? It's not something I had when I lived in the U.S. Like, you cannot do that, right? You have to have insurance, and your physicians have to be in network, and you're going to only be able to access a smaller number of physicians. And the reason I bring them up is the people who built that company were the ones that previously built an app that was doing the same thing with restaurants, right? And that's because they had that in their DNA. Like, if you want to book restaurants, this is how you build a company. This is the commercial arm you need to convince all the restaurants, etc. That's how they built the technology. That they weren't engineering first. It's not, technically it's not very hard to build that. But they knew they had to go and convince every single physician that they had to be on that platform. And not all physicians love them, right? To be candid, right? Like, physicians then, feel they have to rely on this. They don't exist if they're not on the platform. At the same time, it has increased how many patients find them. So their calendars are now, quite dense, and
it's making better use of all of the stakeholders, and it's also alleviating a lot of the administrative burden. There's a lot more to Dr. Lee, but the part of the story I wanted to bring up is I think you have a point in saying, we need to figure out which bits and pieces of the healthcare systems are such that, bringing in ways of doing things from other industries are absolutely acceptable, and which things are things that, we really need humans. And I think we need humans not just because, it's much nicer to interface with a human doctor and have an hour-long conversation rather than 10 minutes with a conversational agent, for sure. But I think it's also that when it comes to your own health, there are many things that as patients we're only going to do because we have that relationship and that trust. And so at a much more profound level, I truly feel that we need those human connections to be healthier. And if we get that completely out of the picture, then we are actually shooting ourselves in the foot in trying to get everyone to really be healthier globally.
Thank you, Joelle. I'll come to Richard in just a minute, but sort of just following on from that, I think that point about the human touch is really important, but also I think maybe it comes to the human factors question as well. One of the things we've seen in the UK is that particularly the under 30s are really happy to do primary care appointments either with a GP they don't know online or else to do it asynchronously using AI of some sort or just regular sort of an asynchronous appointment, because they are a generation who have grown up online. Their lives have been online totally from almost day one, as it were. So, and another thing we talked about at a session yesterday was, we have a company in the UK called Euphonia who use AI to do follow-up appointments for people when they've been discharged from hospitals, so sort of wound care type things, just checking that the wound is okay. And predominantly it's with old people, and they do that via phone calls, and then and it's all fully consented and fully transparent, but they've really thought hard about what do the over 70s want and the experience they want, and actually a phone call for them rather than doing something on an app or typing is actually what they want. So I think there's something about, in terms of that reach and then that human-centered design and kind of AI readiness, it's understanding, it's back to the point that Jakob made and Sivert made, it's about understanding your users and what they need, and if we get that bit right, that's how you drive adoption, and that's how you scale up to your people with, however many, was it 640 million people or whatever. So, Richard, I'll let you take that as well, because it was directed at you.
Yeah, so just a couple of points. So the first point about equity around these models, I think, to your point, I just want to echo what you said. Let's have foundational models and open data sets and allow for countries to then fine tune upon those models or explore those data sets with their local country data. And let's run studies and support studies in low and middle income settings where resource constraints can actually lead to new innovations that have spillover effects. So the example with looking for anemia in the eyelids of pregnant women can also be used in tertiary care settings when you need to do serial investigations and you don't want to keep on drawing blood. So you can think about the potential for how designing for a specific constraint in a focused problem can have spillover effects. So we should invest in those types of collaborations. And to Google's point, I will also say that they've published certain health foundation models other than the large language models that are specific for specific diagnostics. And I think that is the direction that we should try to pursue. To the question about the level of human involvement and how do we keep humanization and personalization at scale, the way that I would think about it is, and I'll use an analogy here, let's think about the weighing scale, right? The digital weighing scale. It's something that is an innocuous piece of technology that is so important to figure out whether or not the baby is gaining weight or is malnourished, whether the person is in heart failure, whether the patient might have cancer. And it's just there. It's invisible. It's in almost any clinic and even in rural settings and last mile settings, and it works. But at the same time, the health provider needs to know, is that scale, does it have batteries? Is it slightly not calibrated because there's a rock underneath and it's not level? And they need to be able to interpret that information in the context of what's happened before and after. So in the same way, I very much see AI as a tool that needs to be invisibly integrated within the workflow that actually adds value. And I think that it is starting to do that. We're seeing how smartphones are being adopted at scale, for example, in India and other settings. So that's really the kind of frame that I take when I'm thinking about AI. Like, is it something that can be easily integrated within the workflow? And that gets to the second question as well, which is like, how do you know like health workers and the system as a whole is ready for the technology that's coming? Well, the technology is already here. The cat is kind of already out of the bag. Patients are already looking things up and coming with more informed questions. So there is this kind of maturity, digital maturity and readiness index that you can think about. But what I would encourage is for policymakers, hospital systems to think about the enabling environment around that. We're going to have an environment with different forms of technology. You're going to have pneumatic tubes and CDs and fax machines, and then you're also going to have large language models that are trained off 1 billion encounters that are going to auto-complete your hospital encounter and predict what's going to happen over 1,000 different simulations. And that's the environment that we live in right now. The question is, how can we make the people that are using whichever tool informed about what goes into them and what are their limitations, whether it's the patient or if it's the clinician at the bedside.
Thank you. Sivert, Jakob, anything to add? No worries.
No, not on that one.
I'm really sorry, but we have run out of time. I know there were lots of questions, and I'm sure our panelists would be happy to chat to people afterwards. But I do want to make sure we finish on time. So I am just going to pull it back to us, and I'm going to ask each of my panelists, if you had a magic wand and you could kind of make one thing happen to accelerate the adoption and implementation of AI into healthcare globally, what would it be and why? Sivert, we'll start with you.
Going to repeat myself, I think co-creation with healthcare professionals as a process. Yeah.
Very good.
I would say share tools and data and make it more human.
Thank you.
I will draw it down to Europe only, if I may. Maybe I can use as an example, but and it's this time of year soon, so a European health data space, successful implementation of European health data space, I think that will bring things together. Yeah.
Very good, thank you. Joelle?
Benchmarks. I think if I have convinced you all to write your own benchmark for what you want models to do, it's been time well spent.
Thank you. So a year ago, we were on the stage. Well, my former boss, Karen, was on the stage talking about the potential. This year, we've talked about implementing. So next year, we will talk about just many success stories. We'll be back to talk about how AI has been adopted at scale for the 640 million people in India with chronic conditions, maybe. We'll invite you that this time. I want to thank Joelle, Jakob, Richit, and Sivert so much for their time this morning. Thank you all for giving up 90 minutes of your last day at the World Health Centre.